هلا اذا الدكتور محمد عزام جاهز وموجود. دكتور محمد عزام اخصائي الصدريه والعنايه الحثيثه في سانت مايكل سيتن هول يونيفرسيتي في نيو جيرسي. دكتور محمد عزام راح يعطينا محاضرتين. الاولى حتكون introduction to shock، والمحاضره الثانيه حتكون عن sepsis and septic shock. محمد، لو انا الطبيب المقيم تبعك وعندي مريض شوك we have appropriately resuscitated the patient initially، شو الاشياء اللي بتتوقعها مني to report back as a follow up on this patient in the following hours and the next day and every day treating a shock patient؟
راح احكي عن هذا الموضوع شوي بالسبسس باندلز. بتحب اجاوبه هلا ولا بالمحاضره؟
يا ريت.
طيب، بالنسبه للشغلات اللي بدنا نتاكدها، مثل ما حكينا انه ناسس الفيزيكال اكزام تاع البيشنت neurologically is the patient is more awake or he's getting more lethargic. The blood pressure, mean arterial pressure, is it improving or is not improving? We have to make sure that the patient is catching up on the urine output. We have to make sure at least the urine output is 0.5 to like 0.5 ml per kg per hour at least. بعدين another blood workup like lactic acid. Is the lactic acid getting better or it is getting worse? لأنه effective management lactic acid, now we want to see over 2 hours at least there is improvement in the lactic acid percentage by 20%, and that is at least the minimal acceptable as a real good resuscitation of the patient. So 20% drop of the initial lactic acid over 2 hours at least, and this is at least what I'm saying, would be the best thing. If it get less than or more than 20% less, that's even better. بس إذا ما راح يصير له drop 20%, that means either you are poorly resuscitating the patient or make sure that you are not missing another diagnosis, because this will affect mortality rate as well.
شكرا جزيلا دكتور محمد. دكتور محمد، المحاضرة الثانية لك، بتحب تاخذ بريك ولا بتحب تبلش؟
لا ان شاء الله بقدر ابلش، بس اتاكد انه راح يصير ابلود للسلايد.
يلا بستنى فيك
ان شاء الله. اوكي، بسم الله الرحمن الرحيم. دكتور طلعوني الصوت واضح كمان مرة ولا؟
الصوت واضح، بس اعمل سلايد ديسبلاي، سلايد شو.
اوكي ان شاء الله. اوكي، الموضوع الثاني اللي راح نحكي ان شاء الله عنه هو sepsis and septic shock. بالنسبة للsepsis definition, sepsis is a clinical syndrome that its definition has been changed multiple times over the years. According to the Surviving Sepsis Campaign 3, the most updated definition is, it's a life-threatening organ dysfunction caused by dysregulated host response to infection. The mortality rate at sepsis is 10%. وإذا المريض بده يصير عنده septic shock, even the mortality rate will go higher to more than 40%. So if the sepsis can progress to be more severe, causing septic shock, which is defined as sepsis with a profound circulatory, cellular, and metabolic abnormalities, clinically this should be assessed after initial fluid resuscitation and in the absence of any more, hypovolemia, by that the patient still require vasopressor to keep mean arterial pressure more than 65 and the serum lactic acid more than 2. هلا بالنسبة للSOFA score, SOFA is based on 6 different scores to determine the extent of the person's organ function and the rate of failure in critically ill patient. As we see here on the table, it is 6 components: respiratory with the PF ratio, the worse, the higher number, Cardiovascular manifested by the blood pressure and the pressure requirement. The bilirubin number, the kidney function manifested by creatinine and the urine output. Coagulation, platelet count, the lower the worse. CNS, Glasgow Coma score, the lower the worse. So as we see, it is maybe complicated to remember all these numbers, and that's why we have the quick version of the SOFA, which help with early diagnosis and try to triage patient to the appropriate floor. So it is composed of 3 numbers: the respiratory rate more than 22, altered mental status, the patient confused, systolic blood pressure less than 100. So this is a quick version of SOFA. هلا الليميتيشن تاعت الquick version of SOFA انه is it septic or is it secondary to severe inflammation? Because we may see it in non-infectious processes like severe pancreatitis as well, and so forth. So we're talking about epidemiology in sepsis. The global burden of disease study reported in 2017 an estimated 48.9 million incident cases of sepsis. Approximately 11 million deaths were reported, representing 19.7% of all global deaths. The incidence of sepsis varies. It's more in African American male. It is more during winter لأنه عندنا more viral infections. As we know, it's worse with older ages as well. هلا بنتوقع احدى الاسباب او بعض الاسباب اللي زادت لانكريز الريت اوف سبسز انه عدد الناس اللي اعمارهم اكبر اكثر في مرضى اكثر عندهم كانسرز على اميونو سبريشن، وفي ناس اكثر هلا قاعدين يستعملوا انتي بايوتيك which will lead لمالتي دراج ريزيستنس. وبتوقع انه فهمنا الاكثر للسبسز وخلانا نصير نشخص السبسز at earlier stages. That's why the number of sepsis, I believe, it is higher. A 2-year outcome of sepsis syndrome, unfortunately 33% they have mortality rate over the first 2 years. معظمهم حتى خلال أول 6 أشهر. هلا في 17% من هدول راح يكون عندهم فرصة أكبر إنه يصير عندهم recurrent sepsis، وحتى 10% recurrent admission للمستشفى. 50% فرصة إنه الواحد to have recovery over the 2 years. هلا sepsis campaign guidelines, they came with recommendation and evidence-based. They come with a strong recommendation when the benefits clearly outweigh the risks and burdens for most, if not all, patients. Weak recommendation, benefits and risks closely balanced and or uncertain. The evidence grade, they put it high quality, moderate quality, and low quality. High quality, consistent evidence from randomized trial or even overwhelming evidence of some other forms. The moderate evidence from randomized trial with important limitation or very strong evidence of some other form. A low quality evidence from observational study and systematic clinical observation or from randomized trial with serious flaws. They came with 93 recommendations, 32 were strong, 39 were weak. لما تكون strong, they start with we recommend. لما تكون weak, they start with we suggest. 18 best practice statement و4 أسئلة ما قدروا يحطوا عليهم recommendation. هلا مثل ما حكينا, history and physical exam is very important. It will direct you and try to narrow you to the source of infection. بدك routine blood workup, CBC, complete metabolic panel, check serum lactic acid, blood cultures, urine analysis. Not necessary urine culture at the beginning if urine analysis is negative. ممكن تعمل arterial blood gas as well. Diagnostic images as directed. إذا المريض جاب difficulty of breathing وcough, بدنا طبعا chest x-ray. بس اللي بدنا نتذكره هلا كثير مهم انه هدول الفحوصات مفروض انه ما يأخرونا عن بداية العلاج. which mean لازم المريض ياخذ فلويد وانتي بايوتيك خلال اول ساعة. اذا راح يصير في تأخير عشان هدول الفحوصات, خصوصا اذا المريض انه شايفينه انه ان سيفير سبسس, ما لازم ناخر الانتي بايوتيك عشان نحكي والله بدنا نعمل البلاد كلتشر بعد. هاي شغله كثير مهمه. هلا اذا المريض عنده شوي هايبوكسيا بده سبلمنتال اوكسجين. اذا المريض ليثارجيك اتاكد انه you are securing his airway. هلا بالسبسس bundle we have the 3 hours with 6 hours and this is very important. هلا ال 3 hour لما المريض يجينا بدنا نبعث له اللاكتيك اسيد، بدنا نعمل البلاد كلتشرز، ومثل ما حكينا ما ناخر الانتيبيوتيك، ادمنستر بروسبكترم انتيبيوتيك، وبدنا نعطيه نبدا بال 30 سي سي بير كي جي فلويد ريساسيتيشن اذا المريض از هايبوتنسيف او اللاكتيك اسيد اكثر من 4. هلا خلال الست ساعات الاولى من هذا الحكي اذا المريض still hypotensive with mean arterial pressure less than 65 that mean انه المريض بده to be started on vasopressor. اذا المريض still is requiring more fluid, this is where we will should be doing recurrent assessment for intravascular volume and resuscitate fluid like 250 to 500 ml as needed. وبدنا نتاكد اذا اللاكتيك اسيد الاول كان عالي to repeat lactic acid to make sure انه it's coming in the right direction. وهذا جزء من السؤال اللي سألته بين المحاضرتين. Meanwhile you have to reassess the patient clinically. Is he more awake? Skin perfusion, the capillary perfusion, the skin warm, the urine output, all of these things. Antimicrobial therapy, strong recommendation to recommend the administration of IV antibiotics should be initiated as soon as possible ولازم يكون خلال أول ساعة لأنه كل تأخير كل ساعة will increase the mortality rate by about 7 to 8%. فإيماجن إذا المريض بده يتأخر الانتيبيوتيك 3 4 5 hours اضرب هذا ب 7 to 8%. هذا you are losing the patient just because of this delay. The other strong recommendation, recommend empiric broad spectrum antibiotic therapy with one or more antimicrobial covering all likely pathogens. معنى تاني انه اذا المريض جاينا وبنتوقع انه عنده hospital acquired pneumonia HCAP بدنا نغطي جرام بوزيتيف بدنا نغطي جرام نيجاتيف that mean انه بدنا نستعمل مثلا فانكومايسين وبدنا نستعمل زوسن. Number 3, weak recommendation, suggest empiric combination therapy to antibiotic of different classes for the initial management of septic shock. In other words, إذا المريض عنده نحكي pseudomonas infection, you can use Cipro as quinolones or cefepime as fourth generation. But again, this is a weak recommendation. The bottom line, early institution, appropriate dosing, correct antibiotic. This will lead to 50% reduction in the mortality rate compared to antibiotic therapy failure or resistant. وبنشوف بهنا بالسلايد على انه على الاكس اكسس time for from hypotension onset. So beyond the first hour, for every hour delay بنشوف قديش المورتاليتي ريت زادت. واذا المريض يتاخر 36 hours انه يصير ياخذ الانتيبيوتيك المورتاليتي ريت will reach 100%. هنا كمان بنشوف انه بالنسبه للجراي bar proportion receiving initial antimicrobial واللي black one the proportion progressing to septic shock. وبنشوف كيف انه خلال كل ساعه تاخير راح يصير المريض progressing more into septic shock with higher mortality rate. De-escalation, early cessation of antibiotic, weak recommendation, 7 to 10 days course or even shorter may be appropriate for most infection, although a longer course may be needed if source control cannot be achieved, as in immunocompromised host, Staph aureus bacteremia, endocarditis, or fungal infection. هلا كتير مهم إنه نتذكر إنه الانتيبيوتيك it has to be discussed on a daily basis as well as all the medication that the patient is taking. لأنه as much as الانتيبيوتيك مهمين إنهم ينعطوا بس unfortunately also they have side effects. They may increase antimicrobial resistance. They may increase C. diff infection, which will lead to higher death. هلا برضو شغله بتساعدنا انه to de-escalate the antibiotic to check nasal MRSA, and this can try to help us in de-escalating, vancomycin as well. Procalcitonin, both are weak recommendation. We suggest that measurement of procalcitonin level can be used to support shortening the duration of antimicrobial therapy in septic patient. والثاني we suggest that procalcitonin level can be used to support the discontinuation of empiric antibiotic in patients who initially appear to have sepsis but subsequently have limited clinical evidence of infection. The bottom line about the procalcitonin, it's a helpful tool trying to differentiate sometimes viral versus bacterial, but still the patient can have bacterial infection with negative procalcitonin. So make sure you have a good sense of what you have. الشغلة الثانية it's a helpful tool try to help later on discontinuation of the antibiotic بس برضو نتذكر انه مش كل مريض elevated procalcitonin has a bacterial infection. We can still see in severe inflammatory processes like rhabdomyolysis, it can increase the procalcitonin. Pathogens, the most common gram positive, then gram negative, then fungal infection. مثل ما حكينا ما تأخر الانتيبيوتيك عشان البلاد كلتشر. الديفرنس بين البوزيتيف انتيبيوتيك اذا بتعطي الانتيبيوتيك قبل وبعد الكلتشر 31% اذا المريض انعطى الانتيبيوتيك قبل و19% اذا انعطى بعد ف 12% الديفرنس. بس برضه بدنا نتذكر انه 50% من الكالتشرز even negative despite whatever. So based on what we know, increase the mortality rate by 8% for every hour. I'm re-emphasizing antibiotic as soon as you can. Total parenteral nutrition إذا المريض بتنعطيه الانتيبيوتيك و he is not improving, start to think about other infection like fungal infection, like TPN patient, severe neutropenic patient is already on brospercam antibiotic after 5, 7, 8 days in the ICU, start to think about other things. Fluid resuscitation, sepsis is associated as we know vasodilation, capillary leak. بدنا نحكي انه the strong recommendation تعطي 30 cc per kg fluid in the first 3 hours. Start them the first hour and to be completed by the 3 hours bundle. We spoke about this in the previous crystalloid versus colloid. I will save some time here. Assess volume status, static versus dynamic. Again, initially, the reverse trial came with septic shock reported a mortality benefit to these static parameter in a protocol-based therapy. شو كانوا يعملوا بالريفرس بروتوكول؟ كان يجي المريض عنده severe sepsis يحطوا له اكسجين اذا بده intubation يعملوا له intubation بس early insertion of catheters فكانوا يحطوا triple lumen subclavian or IJ عشان يفحصوا السنترال فينوس بريشر. اذا السنترال فينوس بريشر اقل من 8 كانوا يعطوه كريستالويد او كولويد فلويد. لما يوصلوا السنترال فينوس بريشر 8 ل 12 كانوا يروحوا يفحصوا المين ارتيريال بريشر. اذا المين ارتيريال بريشر less than 65 they were starting the patient على الفازوبريسرز. بعدين يرجعوا يفحصوا الميكست فينوس بلاد جاز من التريبل لومن. اذا الميكست فينوس اقل من 70% والهيماتوكريت اقل من 30 كانوا يعطوا باك ريد بلاد سيل ترانسفيوجن. بس اذا الهيماتوكريت كان اكثر من 30 كانوا يعطوا المريض اينوتروبيك. This looked perfect. So therapy titrated to CVP mean arterial pressure والميكس فينوس وجابوا data انه this will have a better mortality. But guess what? After that, multiple trials, the process, ARISE, PROMISE, have reported no mortality benefit is associated with the early goal-directed therapy use. So the process, which was done in 2014, protocolized care for early septic shock, it was in multi-centers, 31 United States emergency department, randomized controlled trial, 1,341 patients, 1:1:1 ratio, protocol-based early goal-directed therapy, protocol-based standard therapy, and usual care, the 3 arms. As we see, mortality rate with p-value 0.52, no mortality benefit. طب شو اللي صار؟ اللي صار انه الارم اللي كان فيها more لل early goal directed therapy protocol based in the red and the blue, they were getting more vasopressors, transfusions of the blood, inotropic agent dobutamine وال P ratio كانت less than 0.05 بس same mortality. الفلويد they were getting more fluid compared to the usual care اللي هم ما كان عندهم الأطباء اللي ما كانوا يستعملوا أي بروتوكول بيست. طب ليش المورتاليتي ريت ما تأثرت؟ يعني it looks like perfect بصراحة بس they were giving antibiotic, the 3 of them about 97%, and that's why I'm re-emphasizing antibiotic for the most part and go from there. Arise trial, again, it was done in Australia with New Zealand, 51 centers, randomized trial of 1,600 patients with septic shock. They had the same thing, no difference in mortality, hospital mortality, duration of organ support, and length of stay. They were having the same thing, increase more fluid, more vasopressor, more packed red blood cell transfusion, more inotropic agent in the first 6 hours, with P ratio كانت less than 0.05. بعدين اجى in 2017 Bednarczyk and his colleagues showed that the use of dynamic assessment in goal-directed therapy is associated with lower mortality risk, shorter ICU stay, and shorter duration of mechanical ventilation. فاجوا الفاينل recommendation suggest dynamic versus static variable to be used to predict fluid responsive where available. So if you are able to do them where available, please try to use these. هلا كيف to assess dynamic volume status responsiveness. الموست common هم pulse pressure, stroke volume variability, inferior vena cava variability والpassive leg raise. بالنسبة للpulse pressure, stroke volume variability والinferior vena cava, المريض has to be like intubated, does not have spontaneous breathing. We should put him just for the exam itself on higher tidal volume, 10 ml per kg. They should not be having cardiac arrhythmias. وإذا variability more than 12%, that means that they are intravascular volume depleted, or they will get better with transfusion. بالنسبة للinferior vena cava variation, again, we do at it's the same thing, that they should not be also spontaneous breathing with higher tidal volume. It's ultrasound at bed management بنستعمله ونشوف الفاريشن if less than 12% or versus more than 12%, or resuscitate based on that. Passive leg raise, المنيح في passive leg raise انه we monitor the cardiac output, the patient can be awake or without, even he can have arrhythmias without problem. هلا شو اللي بيصير inspiratory phase of the positive airway pressure? The intrathoracic pressure increase, and this passively increase the right atrial pressure, and this will go to cause decrease in venous return. This will cause distended vena cava. So if the right ventricle and the left ventricle are fluid responsive, the decreased right ventricle with left ventricular output will lead to variability in cyclic changes in the left ventricular stroke volume and arterial pulse pressure. ومن هنا انه راح يكونوا variable. هنا quick thing على pulse pressure variation. We measure pulse pressure max, systolic minus diastolic. وهنا minimal, systolic minus diastolic, divided by the mean is a more than 12%. That means fluid volume responsive. The stroke volume variability بنحط arterial line. We connect it to Vigilio, any commercial available device, وراح يعطينا stroke volume variability as number or percentage wise. هلا we spoke انه ultrasound is very helpful tool, sensitivity 71% with specificity 75%. المشكلة انه الواحد يكون متعود انه يستعمل الالتراساوند. The more that you use it you get better. اذا انت كمان عم تستعمل الالتراساوند على inferior vena cava, you will assess the heart, you will assess the lung, you will assess for even vascular, so it is very helpful tool. اذا بيجي المريض وبتحط الالتراساوند للانج اكزام وما بيكون عنده بي لاينز على اللانج اكزام, بعدين انت you start to resuscitate the patient, we start to have B lines after the fluid, you know that you should not be giving the patient any more fluid because he start to have interstitial or alveolar pulmonary edema. بالنسبة للpassive leg raise, sensitivity 86% with specificity 92%. The patient initially is lying the 45 degree, بعدين بنرفع leg as in this picture 45. That means about 250 ml is pulling from the lower extremity back to the heart as they're giving him a bolus of a fluid. Meanwhile, we are measuring the cardiac output. If there's variability more than 10%, it means that the patient is fluid responsive. We'll make sure انك تراجعوا الانيشال بوزيشن عشان يرجع برضه الكاردياك اوتبوت للسيم ثينج to make sure انه ما في other causes affected the cardiac output. Lactate resuscitation, as we said, elevated lactic acid more than 4 associated with high mortality. make sure as we know
دكتور محمد 4 minutes.
إن شاء الله. Tissue hypoxia, accelerated glycolysis, medication, liver failure can affect that. Early source control is very important. إذا المريض عنده empyema, after that make sure إنك to address that in the first 6 to 12 hours. Chest tube. إذا عنده cholecystitis, consider cholecystostomy. Strong recommendation, as we said, mean arterial pressure more than 65. Vasopressors, my colleague will be talking about it. Norepinephrine first line of treatment. And vasopressin, it's more like it has relative vasopressin deficiency in septic shock, 0.03 unit per minute. We can use it as replacement hormone. Epinephrine recommended as second line. Phenylephrine إذا المريض عنده tachyarrhythmias from الليفوفيد أو adjunctive for refractory vasodilation. ما تستعملوا الدوبامين للشوك. الانوتروبيك agent again إذا عندك المشكلة بالpump itself. monitor الكارديوكاتود والميكس فينوس جاز. حكينا هذا. role of corticosteroid as adjunctive therapy because it downregulates the maladaptive inflammatory response seen in sepsis. وهلا احنا بنعرف احنا بالكوفيد الدexamethasone showed decrease in mortality rate. فاذا المريض is hypoxic please use dexamethasone early. الجايدلاينز بالنسبه للسبتيك شوك in general about 200 ملغ IV per day. ووقفوها لما ما في شوك anymore. من شغلات مهمه بالنسبه هون للبلاد transfusion. Holst and his colleague had a trial. الهيموجلوبين went to transfuse blood أقل من 7 ولا أقل من 9. الداتا showed إنه ما في change أو difference بالmortality. بس there was significant 50% reduction بالarm اللي كان transfused just for less than 7. So recommendation to give if it's less than 7. or strong recommendation كون ما تعطوا erythropoietin for treatment of anemia associated with sepsis. The mechanical ventilation, I will spend just 1 minute here. I know that they spoke about it earlier, but well, we have to re-emphasize, a recommendation target tidal volume بالARDS 6 ml. Keep a plateau pressure less than 30. Recommend using prone over supine position in patient with sepsis, induce ARDS and PF ratio less than 150. وهذا كتير مهم بالكوفيد patient حتى early proning even إذا هم موجودين على high flow oxygen أو oxygen is better. Suggest in neuromuscular is they are desynchronizing with the ventilator or they are having low PF ratio. Try to keep it لأقل من 48 ساعة. Suggest using higher PEEP over lower PEEP with sepsis-induced moderate severe ARDS. Or recommendation conservative. This is very important thing. إنك ما تعطي المريض fluid more than should be. Conservative fluid management. Try to keep him euvolemic or a little bit on the dry side after the initial resuscitation. وما تستعملوا albuterol routinely إذا ما في عنده bronchospasm. Another strong recommendation, pulmonary artery catheter, SWAN is not indicated. Recommend إنك keep head of bed 30 to 45 degree elevated to limit aspiration, prevent development of a ventilator-associated pneumonia. Make sure after you treat the underlying problem, lower oxygen and PEEP requirement, use SVT, weaning protocol, try to not delay your extubation. Good intensivist has 10% re-intubation rate, which means he's not delaying his extubation till everything is perfect. It's normal to have about 10% re-intubation, and this is the best intensivist. Blood sugar, keep it 140 to 180 in the ICU. Bicarb drip, suggest against the use of bicarb drip to improve hemodynamic or to reduce the vasopressor requirement in patient with hypoperfusion induced lactic acidemia. In other words, إذا الأسيديميا من lactic acid, treat lactic acid أكتر من إنك بس decorated with bicarb drip. Strong recommendation استعملوا الpharmacological prophylaxis إذا ما في contraindication. Low molecular weight heparin is better than unfractionized heparin. Stress ulcer prophylaxis إذا المريض عنده risk factor for GI bleed. Recommend to give stress ulcer prophylaxis. Nutrition, early enteral feed to start it if applicable. Make sure lactic acid is getting better while pressors requirements are getting better. Otherwise, you will end with ischemia. So don't start enteral feeding till lactic acid start to get in the right direction. While the pressor requirements are getting in the right direction, you have up to 7 days to do enteral feeding قبل ما consider a TPN or no recommendation or against recommendation for omega-3, IV selenium, glutamic acid, renal replacement therapy. These two are the last two slides. Renal replacement therapy, we suggest against the use of renal replacement therapy in patients with sepsis and acute kidney injury for increased in creatinine or oliguria without other definitive indication for dialysis. معنى تاني ما تعملوا dialysis بس عشان الرقم تاع الكرياتينين قاعد يطلع أكتر or المريض oliguria. Make sure you review the real indication for dialysis and based on that start renal replacement therapy. Goal of care. This is very important, especially with the COVID. Recommend that goal of care be incorporated into treatment and end-of-life care planning utilizing palliative care principle. بعرف بالنسبة لcultural thing, it's hard to talk to the patient's family about end-of-life discussions. But again, I guess it's time to start changing a little bit cultural-wise about having realistic about what's the real medical condition that the patient is having or to anticipate the worst. وإن شاء الله الله يشفي الجميع وإن شاء الله بنكون بخدمة الوطن وخدمتكم. اللي عنده أسئلة خلال هاي المحاضرة بعد المحاضرة أو على الفيسبوك أو على الواتساب كمان إحنا إن شاء الله جاهزين.
يعطيك العافية دكتور محمد، محاضرة قيمة جدا، معلومات very practical. بس بدي ابلش من اخر شيء حكيته، الجولز اوف كير ديسكشن. انا اشتغلت في مركز الحسين، كان في عندنا مطبوعه موجوده على كل الطوابق، فتوى الدي ان ار من مجلس الافتاء الاردني، ما بعرفش اذا موجوده في الحسين. بصراحه اذا مش موجوده بتوقع انه الكالتشر جاي، يعني اذا you have to appreciate, you have to discuss prognosis with the patient. إذا بيجيك واحد already with the lactated 15 وعلى 4 pressors who is not responding, you have to be clear with the family about the prognosis. دكتور محمد، في عندنا اسئله من شكرا على المحاضره الوافيه. It's very challenging for all of us. Fluid assessment is not easy. You cannot judge. There's no one test that's pathognomonic for fluid responsiveness and to differentiate. So we use all of these and we make a clinical picture. There is pitfalls of getting lost by focusing on one number that might guide you in the wrong direction. كان في اسئله من الشات على CVP. Is there still any role for routine CVP pressure monitoring?
Again, the new guideline recommendation is against using the central venous pressure because, again, the accuracy of the dynamics showed there are 50% difference between this and that. So instead of just having one number, you need the actual intravascular volume more than anything else. And again, we know that this will have variability with each cycle. So I know it is time consuming to keep doing ultrasound for the patient to check in vena cava. وبرضه قديش انه you are trained on the ultrasound to start with. هلا other tools الفيجيليو, which is you put arterial line or connected to a device, or it will give you a continuous stroke volume with variability reading. بس في كمان limitation. اول شيء انه مش موجود بكل مكان. ثاني شيء مش معقول تاخذ فيجيليو لكل مريض جوا الاي سي يو. ثالث شيء انه اذا المريض عنده arrhythmias, it will not give you a real reading. I know unfortunately الالتراساوند هلا what I would be recommending if applicable بمستشفيات الحكومة او الخاصة انه بالكوفيد ممكن انه to have multiple teams. This team is just to be checking on patients on ultrasound with inferior vena cava variability, try to help them in putting lines if they want a triple lumen, if the patient is in shock. And another team is to continue treating the patients. So this will offload a little bit on one-man power show and all of these things, وراح تقدروا تركزوا أكتر على better reading و reassessment of fluid و try to avoid the fluid overload, worsening ARDS and worsening outcome.
في سؤال ثاني عن IVC measurement validity in non-intubated patient? Is it still as good in an intubated patient?
Ideally, the patient should not be having the spontaneous breathing. Ideally, you should be having tidal volume about 10 uh, ml per ideal body weight. هلا إذا بتعملوا على spontaneous breathing إذا الانفerior vena cava is very collapsed or everything looks like the patient is dry. Again, this is a valid tool that you see the right ventricle is collapsed, the inferior vena cava is collapsed. I would go with more fluid resuscitation. But عشان نعمله more accurate, that's why we'll be checking on the lung with B lines. So if the patient was not having B lines وقاعد انا اعطيه فلويد وبرجع اعيد له الانفيريور فينا كافا اكزام وبرجع بعمل له لانج التراساوند وستارت تو هاف بي لاينز ذات مين انه طب هو اجى ما كان عنده بي لاينز واللي بدا هلا يصير من البي لاينز most likely from my fluid resuscitation as early sign انه he start to have interstitial pulmonary edema and that's why I should question myself now, does he need any more thing or not? Now we have to remember one more important thing, which is sepsis is a vasodilatory problem, which means the treatment is not just continue giving fluid, because this fluid will continue to leak outside. So initially it's fluid, but you need something to have constriction for these vessels. So it is one plus the other one. Try to have the better outcome.
شكرا كثير دكتور محمد. One more question لأنه we know it's probably not very abundant utilization of ICU and fluid assessment. To a lot of people who are not critical care trained will be taking ICU patients, shock patients. There are some more practical. Would you talk to us for 1 minute? Just I know you talked about, but re-emphasize the value of mixed venous SAT, how to obtain it, how to interpret it, the value to differentiate cardiogenic shock.
إن شاء الله. So بالنسبة للmixed venous blood gas, ideally you have to have this one catheter, but we can also get the superior vena cava oxygen saturation by placing either IJ or subclavian triple lumen. We get blood gas from there. We need a saturation from that blood gas about 65 to 70% and more. So what happened in congestive heart failure or in patient with severe anemia, the number of the oxygen saturation will be low. With patient with shock, this number will be low. ليش؟ لأنه الفلو تاع البلد is low. This will have more time for the oxygen to be extracted to the tissue. By the time they are coming back to the right atrium, the superior vena cava and the right atrium, this will have more time, and that's why they will have significant drop. Compared the patient with sepsis, as we said, it's a hyperdynamic left ventricular contractility. The circulation is very fast, and that's why the oxygen saturation in the mixed venous usually will be more than 70%. So this is a quick tool try to differentiate congestive heart failure / anemia versus patient with sepsis. Both are having shock. Now, let's implement this. So if the mixed venous blood gas 65, 70 or above, you're done. But if it is low, that means either it's anemia or congestive heart failure as component. If the hemoglobin is anemic with hemoglobin less than 7, make sure you give blood transfusion. If the patient is anemic with active MI or worsening lactic acid, we can also give PAC-RBC to maintain it even a little bit higher than 7, 8 or 9, trying to support that. But after that, if it is still low and we believe that the contractility of the heart is low, I would be starting the patient on inotropic agent, which would be either dobutamine or milrinone. What's the difference? We have to understand dobutamine is very good contracting agent, but it is very arrhythmogenic. So if the patient is having arrhythmias or VTAC, VFib, I cannot use dobutamine in this patient. I will be using the milrinone, which is a phosphodiesterase 3 inhibitor. it has good, or mild inotropic contractility, but the problem that it may drop the blood pressure. Let's say that I was able, or you can use also epinephrine. Now, I started this medication, and I would say the initial mixed venous gas was saturation about 40%. And let's say that I started the patient on dobutamine, whatever dose. And after 30 minutes or 1 hour, I will tell my fellow or resident, I need another blood gas in about 30 minutes to 1 hour to see, does this dose, whatever he is on, improve the mixed venous gas? Let's say that the mixed venous gas went from 40 to 50. That means this dose is helping, but still maybe not ideal. So I tell them to increase the dobutamine dose again and check another blood gas for saturation as a mixed venous in another 30 minutes to 1 hour. And let's say now the number is back to 65 or 70. That means that this dose of dobutamine or Merinone is the right dose for the patient. So it is a continuous. There is no wrong and right dose. It's more titration based either on the mixed venous blood gas, or if you connect the patient to like a Vigileo through arterial line and you see improvement in the cardiac output, which is another tool to make sure that your cardiac output is between 2 to 4, or cardiac index is about 2.4 to 4.2. So dosing the inotropic agent based on mixed venous, based on cardiac output, cardiac index, but again, the way that we are doing it is based on that.
شكرا كثير دكتور محمد، الله يعطيك العافيه، محاضره قيمه.
الله يعافيك ان شاء الله، وجزاكم الله خير ان شاء الله.